All right, it's still good morning, Nigeria, on the network service of the NTA. And to begin our conversation this morning as regards issues in Nigeria's health coverage, specifically on the National Health Insurance Authority. Here's a background report put together by our correspondent, Abdusalam Jubril.
As the popular saying goes, health is wealth. There is therefore a clear nexus between the state of healthcare in Nigeria and its economic situation. However, over the years, some experts say the country's healthcare industry is facing challenges associated with outbound medical tourism, deteriorating medical infrastructure, low government budget allocation, poor compensation, and subsequent emigration of skilled healthcare workers. In 2005, the National Health Insurance Scheme was set up by the federal government, operating as a public-private partnership and directed at providing accessible, affordable, and quality health care for all Nigerians. Some health experts maintain that despite the introduction of the scheme, evidence abounds that most enrollees still find it difficult to access health care because of some factors militating against the smooth and easy access to the scheme. They insist that as a result, many people continue to die of preventable diseases as they cannot afford the catastrophic medical bills outside the National Health Insurance Scheme, now National Health Insurance Authority, while those who can afford the out-of-pocket medical expenses spend most of their budgets on healthcare services. Other challenges identified include the rapidly growing population, coverage to only one sector of the population, lack of awareness of the scheme, distrust, shortage of human resources, and lack of funds to implement the scheme. Last year, President Bola Ahmed Tinubu launched Nigeria's Health Sector Renewal Investment Initiative, a bold plan to accelerate Nigeria's journey towards universal health coverage, bringing better health and care to every Nigerian. It aims to increase in health insurance coverage from 7 million to about 50 million people, or about 700%, within 3 years in Nigeria. How much success has the initiative recorded so far? Recently, the Association of Nigerian Private Medical Practitioners threatened to pull out of the National Health Insurance indefinitely, shutting out some of the 16 million enrollees covered by the scheme. How should this be adequately tackled? What are the issues in the National Health Insurance Authority and universal health coverage? These are just some of the issues guests on the program will be speaking to shortly.
All right, thank you, Abdusalam Jibril, for that background report. And right here in the studio, we have been joined for this conversation by Dr. Kelechi Ohiri, Director General, National Health Insurance Authority. It's a pleasure to welcome you to Good Morning Nigeria.
Good morning. Thank you for having me.
Okay.
All right, also with us for the conversation is Dr. Gafa Alaudi, expert in health financing. Many thanks for joining us, Dr.
Good morning. Thanks for having me.
All right, also joining us for the conversation via Zoom is Dr. Olumuyiwa Olusonya, CEO, Insignia Health Limited, General Secretary of Health and Managed Care Association of Nigeria. Many thanks, Dr. Olusonya, for joining us.
Okay.
Good morning. Thanks for having me.
Begin from here in the studio by the CEO of the NHIA. Let me ask you to give us an insight into what is obtainable, with at the health insurance level. How many primary health institutions, how many primary, secondary health institutions are registered, and what kind of service, what quality, what amount of service are those enrollees entitled to at this time?
Thank you very much for the question, and good morning, and again, thank you for having me. I think it makes sense to, start by really trying to at least articulate, what role the NHIA plays right now in the context of expanding financial access to Nigerians. In 2022, an act that established the NHIA was enacted and passed into law. And what that act mandated the NHIA to do was to promote, to regulate, and to integrate health insurance schemes. And I think what that means for us is that most Nigerians who have been covered by health insurance can actually expect that when they go to a facility that they don't have to pay out of pocket. Yeah. And the purpose of this was to ensure that Nigeria already has real high out-of-pocket expenditures in health. Only 7% of Nigerians are covered by insurance, and we know that about
7%.
About 7% of Nigerians are covered. That's roughly 16 million people. And over the last 20 years, that number was actually lower and almost stagnated at roughly 5%. And that was because largely it used to be voluntary before the Act in 2022 was passed. So that meant only those who probably saw the need or appreciated why prepaying for health care would add to financial protection, or those who, by reason of employment in the formal sector, had access to that had it. And so this contributed to the low levels of coverage that we've had so far. But with the Act now making it mandatory, it means that now we actually have a pathway to universal coverage where we aim to actually increase the coverage of Nigerians from 7% and to see how far we can go, because of course there are things that have to happen for that to occur. So the NHIA's role has evolved as a result over time from being just a scheme that catered to largely public sector and the organized private sector to an authority that, in addition to providing insurance coverage for the formal sector, also regulates. The second thing about the Act that is quite instructive is the establishment of the Vulnerable Group Fund. And this is because we recognize that health insurance could be contributory, where you prepay, but it also could be non-contributory, where somebody like the government pays on behalf of the poor and vulnerable. And so the Vulnerable Group Fund was a critical part of this scheme, where we're saying that for the poor Nigerians, for those who are classified as vulnerable, including internally displaced persons, the elderly, and under the mandate of the Coordinating Minister for Health and Social Welfare, in tandem with the President's agenda, in an attempt to crash and reduce maternal mortality, we've expanded the definition of vulnerability to include women who are at risk of death during childbirth, because that disproportionately affects poor women, mostly in rural areas. So a fund that helps to not just address their index issue, but also ensures that they are enrolled in insurance so that in their journey through life, their care is covered. So that's mandatory part. The Vulnerable Group Fund was also an important element of the NHIA Act. A third part which it has spurred is that over the last 2 years, now every state in Nigeria has a state health insurance scheme. And the last one to actually come on board was Rivers State, and they've actually set up a scheme. And why this is really exciting and important is that, in our federal structure that we have, it's important that not just the state civil servants and the formal sector come on board, but many states are setting up equity funds to also complement what the federal government is doing to ensure that even the poor and the vulnerable in their states are also covered. And this has given rise to an increase in the number of people who are covered by health insurance in Nigeria. And lastly, I'll also mention that it's not just the public sector that is involved. We have a mixed healthcare system. So to your question about both public and private facilities, they are bound, and we have a lot of providers who are working hard and providing care to Nigerians, in spite of the challenges that you've mentioned, like brain drain, etc. But we also have a mixed insurance space, where we have not just the NHIA and the state health insurance schemes, but we have a lot of private health insurance agencies, HMOs, as well as administrators. Some of these HMOs were there even before the NHIS was set up, and have been part of the journey in insurance in Nigeria, and have actually covered quite a lot of Nigerians. So it's quite an exciting space, right, where we have both the public and the private sector coming together. And as you know, I had a meeting with the UHC Forum that Dr. Gafar is a pivotal member in. For Nigeria to actually increase coverage of people, and for us to go on that path to universal healthcare coverage, it requires collective effort of both the public and private sector, but also the federal government, state governments, and the indefatigable civil society organizations who have played a critical role in Nigeria's UHC journey. So upon assumption of this role, it has been one of our priorities is to engage and make sure we carry stakeholders along in this process so that we can all complement each other and the respective roles that we play.
All right, many thanks, Dr. Ohiri, for that insight into what the NHIA is really all about. But you said that it's an exciting space, and some Nigerians may want to disagree with that comment about because of the so many constraints, if you like, challenges, problems that they get to face having been enrolled in the NHIA. Could you speak to us about some of the constraints? I'm sure you're aware of them.
There are several constraints. There's a constraint of coverage. It's still quite low, right? And a lot of Nigerians, unfortunately, disproportionately pay out of pocket. And when you look at a household where with the current economic situation in the country and inflation, limited disposable income, so it means that anytime you are ill, you have to dip into that pocket and pay for care. And you pay at the time of vulnerability when you need it. So 7% coverage is not enough. So there's that problem. There's a problem of equity as well, where for a lot of people, they are too poor to even contribute to any scheme. And so we must find better ways of mobilizing resources to ensure those people are covered. The point you're probably alluding to is the issue about quality of care and dissatisfaction when people actually go to the hospital. And lots of reasons abound to that. One of these is really the fact that the quality of care could be compromised if tariffs are low, right? And one of the things that we observed is that it's been a while since tariffs were actually reviewed in the sector. And one of the first things that we did in the NHIA upon resumption was to commission actuarial reviews, which started in February, so that we actually have the evidence and the basis to review tariffs in the country, and also from an actuarial perspective, understand what we can afford in terms of a basic minimum package of services, so that if you go to a hospital, you know what to expect to have. That's also a big constraint that we've been working. We also have an enforcement team in the NHIA. Over the last year, we had to mediate and intervene when we have complaints, because we take it seriously. We want the complaints to come because that's the only way you get feedback. But it's not just enough to have complaints. You have to do something about it. Over 3,000, 90% of them were things that we mediated and resolved. And these complaints could be from our beneficiaries, it could be from hospitals, HMOs in the system, all feeling the pressure of the rising costs of healthcare. And medical costs and medical inflation usually outstrips even just the general inflation. So we're hopeful that, with the review of tariffs, with the increased enforcement, and also with every stakeholder knowing the role that they need to play in actually ensuring that the average Nigerian that goes to a facility receives the quality of care. Insurance has to mean something, and it's a trust. It should mean that if I am insured and I go to a hospital, certain things should be taken for granted. One is that whatever ails me, I will have a solution to it. Secondly is that for that solution being provided, I shouldn't have to go bankrupt paying out of pocket for it. If those things are not there, it erodes trust. And that's why over the last 10 to 20 years since insurance, we've had a lot of complaints and a lot of things that we've been trying to, but it's not just enough to address the symptoms. We have to address the root causes of these problems. And that's why starting with evidence, knowing what is really a fair tariff, what is the appropriate benefit package Nigerians must enjoy, and mobilizing the resources to make that happen are critical, and we must address these things.
All right. Thank you, Dr. Hiri, for your opening remarks. We'll get back to you certainly.
Sure.
But let's, before we get to Dr. Jafar, let's welcome Dr. Wada Ibrahim, who is, has just joined us. He's CEO of the NISA Medical Group. It's a pleasure to welcome you. Good morning.
Good morning, Nigeria. Very happy to be here again.
All right. Let's ask Dr. Jafar, what would you say is responsible at the moment when people go to the hospitals and meds, basic medications for diabetes, for high blood pressure that were hitherto available, are suddenly no longer available, and you are told to go, and we'll get back to you, or we'll call you when it's available, and you never get a call back. Is that a way of discharging the patients? Is it that the meds have gone out of the coverage of the scheme, or maybe because of high prices now for medications and all that? What would you attribute it to?
Okay, thank you very much. And once again, thanks for having me. I think the DG has actually laid the foundation for what the problems are. So, and the providers are here, and they're also in good position to share the experience. But from what we have seen so far, like the DG said, the premium set and the tariff for that is the amount the health insurance will pay the provider for providing certain services, including medication, laboratory, and others. I think they have been there for many years without being reviewed. And after, of course, we are aware of the inflation, the price of everything has really gone up. And again, probably as a survival mechanism for the provider themselves, they rather don't provide some services or don't give some medication because they are not there to run at a loss. So there is a big issue of the financing, the issue of a tariff, whether it's appropriate and what other view. I think that is very, very central. Apart from probably rare cases where the provider themselves want to game the system and not really provide the system. I don't think that's the really big problem. I think the big problem is the amount that is available to the providers to provide the needed services is grossly inadequate. And to solve that problem, and that's what DG have said, is that to scientifically determine how much, and based on evidence, what is the appropriate amount to give to the provider to pay for the service that reflects our economic situation. So like I said, the provider is not there to provide the service. But of course, there are other bigger problems apart from the issue of money not being available. There are issues with the quality of services at times. Of course, part of the problem with the quality of service is the availability of fund or lack of it. Part of what contributes to problem of service delivery or quality of service, having the human resources that is actually needed. All of us are aware of the Japa syndrome. It is very, very lucrative to move from this end of the world and other end. And these are the human beings that are supposed to be providing the services that are actually needed. There are a number of health facilities that some services they were able to provide before, they are not able to provide now because the manpower is not there, including both government facilities and private facilities. So that big issues as well. And I think there is issue of ability of the insurance agency, and I'm happy that DG is on board. He wants to address that issue. Ability to timely get feedback from the patient that are assessing the services. That okay, what is your experience with that? Like you always say, health insurance is a product, and everybody that is producing things is interested in what the consumers are experiencing like this. So I think that institutional capacity, and I'm very happy it's looking at it, ability to from time to time find out from the enrollee what is your experience when we visited this facility. Did you get the services you are supposed to get? I hope you are not spending too much out of pocket, because the essence of health insurance is to ensuring that we are not spending so much out of pocket. So of what you use, if I'm insured and I still spend exorbitantly, and the way of spending is that, oh, this commodity is not available, I have to go and buy it outside and everything. I think so we have to look at how to solve the issue of financing and strengthen the institutional capacity on the part of the insurance agency at the national and the state level, and work closely with the providers as well, so that they are doing their best, and then the HMOs, because they are very, very important factor. But again, in terms of a real thing that we need to do, because if you look at healthcare, somebody says, if you want to make a progress, go and look at somebody that has made that progress, try to study what they've done. So if you look at some countries in Nigeria, in Africa, in our own African context, how they've been able to make very good progress is like, in addition to maybe allocation, routine allocation from government, they've been able to find out what are the additional means of spending. If you look at Ghana, Ghana has been able to dedicate certain percentage of its value-added tax to paying for health insurance. And that is why Ghana has been able to cover up to 50% of the population or thereabout. So again, the NHIA is looking to that. There are a lot of analysis in terms of where could be the additional sources of funding that we can look into to mobilize. Because like the DG said earlier on, no matter what you do, even we say the premium is 5,000, many Nigerians are not able to afford it. So how do we pool resources together to be able to do that? I think that is going to be very, very central for the success of the new administration at the NHIA, which of course is a priority, because DG has told us time without a number. We had a meeting with him yesterday. That coverage is very, very key to him, to ensure that more Nigerians are covered. It's a bit shameful to say the giant of Nigeria is only 7% of
Giant of Africa.
All right, Dr. Lawal, thank you so much. We're
Yeah.
talking about the number being limited at the moment, 7%, and the 7% at the moment are not even satisfied. So I'm worried, if you increase the number, what happens to the effectiveness of the scheme? Dr. Ibrahim, my question is to you. I want you to give us an assessment of the scheme so far. It's been 25 years now. Before 25 years, and we're still talking about 7%. You still go to hospitals today. Those who are already in the scheme, the 7%, cannot access quality medicines. If some hospitals, do not even pay attention to those who are on the NHIS scheme, I do not know what the constraints are between the hospitals and the HMOs. You could have an emergency before you get cleared by your HMO. It takes hours. I mean, a lot of people just dump the scheme and prefer to just pay out of pocket in order to save their lives. So, speak to us really.
And thank you very much. And also to thank the NTA for continuously beaming light on our issues on Good Morning Nigeria, and to appreciate the DG. I thought it was Executive Secretary, but everybody calls you DG. Let me follow and say so. Congratulations on your new assignment. The Lord help you to push the scheme to the next level. And I'm fortunate in a way to be here to speak, because I was at the birth of the NHIS, that's now NHIA, many years ago. The first Executive Secretary, Dr. Mohammed Lekki, is like a brother to me. So I've practiced it from the point of view of the public sector at the National Hospital for a number of years. We initiated it because I was CMAC at the hospital at that time. I've seen it through the private sector, and I've also seen it through the PPP at Garki Hospital. So I feel in a privileged position to say good words, really, because it's not like we have a choice. Condemning NHA does not solve Nigeria's problem. We are here to talk of how to make things roll. Points have been made by Dr. Jafar very clearly that we've underfunded the most fundamental part of our existence. I have no doubt about that. Meaning, your real wealth is your health and nothing else. It's not your mansion, it's definitely not your car or anything else. But that's where our weak point is. We are paying pittance to look after health, and so the crisis, if elucidated in all sectors, whether it's public, private, PPP, they are struggling in a function of our existence that should be surplus, not struggle. So the reasons why we have issues, poor coverage, it is not attractive in the first place, because we are underfunding what is existing. Nobody's clapping, oh, I'm NHIS, I'm comprehensively covered, I'm happy. That will encourage anyone else to say, take me there. We don't have that. And we need to have that, because health is all we've got. People should realize that when it comes to health indices, we are in like a war-torn state. We can only compare with the countries that are not at peace. Bottom of the ladder. That's not Nigeria. That's not our anthem. That's not our creed. We, in everything we say, from our national pledge to our national anthem, we are supposed to be number one in the world. Let the world follow us. And health is the shining example of those who really care about themselves. So what do I offer? Like I said, it's positive solutions, not condemnation. I gave it a thought at the very beginning. Oh, Nigeria, how I wish you said all newborn Nigerians are covered with the support of their parents, and they grow through it, and the rest of us just go on a perfect insurance system. You know, you're a newborn, you're covered. You're a school age, in that order. You're a pregnant woman, you're covered. And systematically, before you know, we have a system that everybody wants to log on to. We missed that chance. We wanted to start with federal public servants and all that. These are people who already earn. They are even better than my grandmother and the newborn, her grandchild, to survive. So we started on not the needy node, not those who need it most, and not in a systematic growth pattern. So let's leave that. We missed the chance of doing neonate, school age, pregnant mothers, then migrate to adults. We just jumped in. What can we do now? There are many examples. The other advantage is I practiced with the NHS in England almost 8 years before I returned to Nigeria. So I've seen it. NHS, you can expect the world on it. Why? If I'm Director General of NHIA and my salary is 1 million a month, say, I pay a percentage of that. But if I'm a cleaner in the office and my salary is 100,000, I pay a percentage of that. I don't know how effective that is, but it's his brother skipper thing. So the more you earn, the more you contribute, so you can level the playing field the way NHIA correctly does. Life is life. Why should you treat a DG different from an ordinary public servant? You know, the scheme does not discriminate. I love that. But brother skippers means those who have more means in society must significantly pay more to look after those who have less means, including the unemployed and so on, those who lose their jobs. But that is the beauty of the UK. Even there, they still have NHS add-on. You have heard of Bupa. You've heard of AMI, insurance. They are top-ups. They are not mutually exclusive. It's a citizen's right to be covered. If it is a citizen's right, some people's wealth is not in naira and kobo. It is in products. We also need to get to a point where we say, I am a rice farmer. The price of a bag of rice is maybe 30,000 or 40,000. Bring 2 bags and we can cover you, because we're going to send you to a mill and they're going to sell it abroad or this and that. So your sweat is money. You are a yam farmer, the same. If we need to expand it, because not everybody is earning this cash like civil servants, we need to be smarter to expand the options. You remember those days of cooperatives? You make your product, you come, they value it, they say go and collect your money from that. That is one way I have, that we can look at non-monetary ways of expanding the cover. 7% after 25 years, excuse me, sir, nobody can give you 100% pass mark. New thinking out of the box is needed. It is our wealth, it is our health, and we must do whatever we can, and many other innovations to get out. And Ghana, I love Ghana, but we should be the ones showing example to Ghana. Kigali, what's that? Rwanda. I love Rwanda. We too, being the giants of Africa, should be calling them, come and see how we do it. So, sir, as a citizen, as a practitioner, I believe we have a chance to succeed. I have no doubt about that. And I'm one of those who are willing to, first of all, pray, because we do that a lot in Nigeria, but act to get the scheme to an enviable position.
No, Dr. Wada, let me stay with you. You're talking about expansion. Yes, desirable. But Yenre also talked about, effective coverage of those that are in the scheme already. Today, you go to the hospitals, including Garki Hospital, since you have identified Garki Hospital as part of it, you go there and basic medications for diabetes, for high blood pressure, are no longer available. Why? It was available before,
yes,
and suddenly it's no longer available. What exactly is the problem?
I think Dr. Jafar very, very eloquently described what's going on. The money we have going into NHS, which I've also said is too small, it's a pittance, can no more fund as much as it was intended to fund. You know what happened to the dollar not too long ago and the naira parity. We are not a producing nation. We still have to import many of those diabetic drugs and all that. So when the dollar runs away from the naira, the prices of goods equally run away, and what you have in your hand cannot. It was bad enough 10 years ago. So think, if we retain the same thing, it's even a worst case scenario.
Thank you, Dr. Ibrahim. I'm surprised that Victor is talking about drugs for diabetes and hypertension. That's a big one. Malaria, you hardly find drugs for that, or even a headache. So anyways, let's go to Dr. Olusoya now. I want to hear your perspective, and I want you to speak from the perspective of the HMOs. What your problems really are, because the hospitals don't want to deal with NHIS patients anymore. I do not know what the problem is with the HMOs and the hospitals, and what your challenge is with government. Speak to us about that.
Okay, good morning. Thank you for having me. I would like to start by first saying good morning to DG CEO, Dr. Kelechi Oyeri. It's nice having you on this discussion, and I'm privileged to be here. Dr. Wada and Dr. Jafar, good morning. On behalf of the HMOs and the Health and Managed Care Association of Nigeria, I would like to say that there is no easy road to success. That's the truth. And where we are is a journey in achieving universal health coverage in Nigeria. And there are supposed to be challenges, there's no doubt about that. The truth about it is that we need to come to the reality that health is not cheap, healthcare is expensive. And what we've been trying to do over the years since the beginning of the scheme is to provide cost-effective, look at the available and meet people at that level. And that's what even the scheme has been doing. It's not that it's perfect, it's not the best in the world. Just like Dr. Waja just said, the resources at the disposal of NHIA to provide social health insurance for the generality of Nigeria.
Having an issue with the connection to Dr. Olusoya. I'm sure we'll get that. Okay, Olusoya, we can hear you. Looks like connection is better.
Yes. So I was saying that the resources at hand, the resources available to provide these healthcare finances is actually too small. And Dr. Wada just confirmed it. I'm sure my DG also will confirm that. So what we're trying to do is to see how we can provide cost-effective care given the resources that is available. Even for it is that most people can afford to pay the true cost of financing healthcare. So if we're going to design the way we design our plans, the way the plans are designed, if we're actually going to cost it based on what premium services should be, most people actually cannot afford it. So what we do working together with our stakeholders is to actually design and work on pay. And that's the reality, that's the truth. Until we have an integrative social system that makes everybody contribute, just like Dr. Raja said about the UK, and makes everybody contribute a percentage of your earning, whether you're rich, you're poor, everybody brings into the pool. We can't have that, that cost subsidization give us the kind of effect that we need to have in the health insurance scheme. But I will not say that we should throw away the baby with the bathwater, but I think that what are the lessons we've learned so far? What are the things that we have achieved so far? First of all, I would like to commend the federal government for starting the scheme. I'd like to commend all the successive leadership, the NHIA, for actually pushing it this far. The truth about it is that the scheme is established already. I think that's the first thing we've achieved. Secondly, we have been able to achieve some form of support, solidarity, especially from stakeholders, HMOs, healthcare providers, and other stakeholders in that space on this social health insurance scheme, which I think we should focus on. At this time, we know that support is worth a lot. What is remaining right now is how do we scale up financing from the public side, from the private sector side, to make sure that we have a very good healthcare system, a healthcare insurance system. The private sector is trying, we're doing a lot to support the social scheme, but we have to realize one thing. If healthcare, the quality of healthcare will be scaled up, it cannot happen in the absence on people actually improving their lives, earning better wages, earning better incomes, because that's where it's going to come from, except the government is willing to subsidize everybody that cannot pay. And so you cannot take it away from the economy and the economic growth of the country. But having said that, government everywhere in the world has to prioritize healthcare. And since health insurance has been agreed, is understood as the best platform model to actually provide quality healthcare across the world, it's now government to look for, let's look.
We may have lost Dr. Olusoya again, but he's made a lot of points. Let's just get back to Dr. Ohiri here. Now, Dr. Wada, Dr. Gafar have made points that what is available can no longer provide what was provided before now. So I wonder why not make this known rather than tell people, for instance, to go and we'll get back to you, or come back in the next 2 days, or come back in the next 3 days. That's one. And there are other basics to deal with. For instance, the information we have is that your systems at the NHIA is having issues. And that poses a challenge to those who intend to access services. Has that now been fixed? These are basics, bottom. Has that now been fixed? Or is still there as a problem? Okay. Because we have to start from A to get to B.
Thank you for your question. So I'll take your first question. Thank you for the comments from my colleagues here. The fact that, to go from 7% to any form of universality requires resources, I think it's clear. It's clearly known. And I don't think that the NHIA or the government's position has ever been go and then come back or to keep quiet. I think the first point I mentioned here was that under this administration and led by the Coordinating Minister for Health and Social Welfare, the NHIA as an institution and the way we have approached insurance over the last 20 years needs a fundamental reform. There definitely needs to be a change in the way we do things. Now, specific to the costs, and I think that was the point I made earlier on, one of the first things we did in February when I started was to institute an actuarial review of costs, because you can't be arbitrary about this. It has to be based on evidence. Yeah. And in insurance, which is the business we're in as well, there are very clear ways of estimating costs by engaging two separate sets of actuaries to look at our benefit package, look at the risk pools that we have for the different population groups we target, and also re-examine the tariffs that have been paid. These tariffs have been there for the last 10 years, have not changed. This is the first time in 10 years that we're actually sitting down to say, let's go to the root cause of all these problems and begin to address them. So yes, I'm not going to deny that the schemes over the last 10, 20 years have had challenges, but I think it's also important to reflect on what are we going to do to move Nigeria forward. financial protection, insurance still remains one of the best options we have to protect people from out-of-pocket costs, and we are definitely on the track to fix that. In countries like the UK, Ghana, etc., they have, in Ghana it's VAT, right? That is financing a significant chunk of it, and they've gotten to a point where they also don't have to think of mobilizing more money because it's in trouble. The NHS as well. When I lived in the UK and I worked significantly supporting and advising the NHS, national insurance is something everybody pays. That helps support it. And even the NHS has come to a point where waiting times, etc., they have to figure out how to properly finance it, because we're experiencing JAPA here. In the UK, doctors are leaving to Canada, to Australia, to other places. The health sector is a complex and dynamic system. And so at every point in time, to sustain, even just achieving and sustaining that, you have to think through financing. And as the Secretary of HM mentioned, it's not cheap, and we have to really creatively look at fiscal space. Now, in Nigeria, how many people pay taxes? So if we were to centrally finance that, we have to deepen our ability to mobilize resources from the government. Now, the government, through the National Health Act of 2014, committed 1% of the consolidated revenue to primary care. 50% of that goes to the NHIA, which is being used as part of something called the Basic Healthcare Provision Fund to provide coverage for the poor and vulnerable. And quarterly, monies are released to the state health insurance schemes to cover people. Over 2 million people have been covered under that. And the last tranche was released at the meeting of the MOC recently. So efforts are being made to narrow that gap. For us in Nigeria to actually begin to advance towards that, one is, yes, we need to mobilize more resources, but we all know the fiscal situation in Nigeria. That's not going to be a quick fix. Secondly, there are those who can pay, but right now are still paying out of pocket when they need. That is inefficient. It makes them vulnerable to catastrophic costs. What we're saying is that go through health insurance, because that way we can pool the risks. When we all contribute money through Esusu, I think something many Nigerians do, 10 of us can come together and say, we all put in 1,000 naira. Because at some point, somebody will have a need that they can draw from that. Maybe it's 10,000 naira. And that's how insurance, in a very rudimentary way, works. It's not that the people who are well cross-subsidize those who are sick. And in progressive insurance mechanisms like the ones we operate here, it means those who have more are paying more. Because as Dr. Wada mentioned, we do not discriminate. We do not have in the NHIS schemes a lower benefit package based on your income level, etc. So there's cross-subsidization, and that is actually happening. Now, in terms of the issue about people facing challenges, and I think it's one thing, we have done things at two levels. One level is, yes, enforcement. People have a right. Insurance needs to mean something, and we're doing that. But but stopping there is just treating the symptoms, which is what we've done before. Where you interact, what we have done with provider groups. With the Guild of Medical Directors, we interacted with the Association of Private Medical Providers, we've interacted with the HCPAN, which is the healthcare providers. So we've met with a lot of them. We've had several engagements with the HMOs, with the states, to understand why are we having these conflicts. And this is one of the things that we've started to do. And then when you get to the root cause of it, some of it comes down to the bottom line, which is the tariffs. And so it made us realize that, okay, the exercise we started in February, which is independent and is going on right now. So because of the sensitivity, we had to get independent bodies to do this actuarial analysis. So that it's not NHIA coming up with something. And that will set the framework for us to determine and review the tariffs and the cost of things. And once that is sorted, you'll find that people will go to the hospital. They'll be able to get those drugs because it is now better financed. One other point to mention is that there is a difference between the average costs of getting care and the actuarial costs. And this is because more people get covered, the pool of people, the risk becomes more manageable. If you have 10 people, 5 of them have malaria. The money that you've been given to manage malaria will not go around. If you had 100 people and only 5 people had malaria, chances are that you have more money because the contribution of those people who are well cross-subsidizes those who are sick. So we have no choice but to expand coverage. So the more people are covered, even the more affordable it becomes for people because the actuarial cost and what you have to contribute is smaller. The easier it is for the doctors and the providers to provide care because the capitation they receive is for a lot of people, and that cross-subsidization works. And so that's why, in terms of priority, we've highlighted 4 things. One is expanding coverage, because that is foundational and fundamental. 2 is the issue of quality of care. Once we solve some of the problems that I've highlighted in terms of the tariffs, then enforcing quality becomes a thing. But it has to be setting the mandatory minimum.
That's a regulatory role.
Absolutely. And that regulatory role we only got in 2022, which is because predecessors understood some of these factors. The third thing is equity. We have a poverty problem in Nigeria. And right now, those that don't have a pocket cannot pay. They can't even contribute the premium. So we must do something to cover them. So the Basic Healthcare Provision Fund has started that journey. The Vulnerable Group Fund, for which the government is appropriating additional resources, is a step in that direction, and we'll progressively get there. And the last one, sorry, just to mention, is the how do we hold ourselves accountable as an industry? Public sector, private sector. And that speaks to our role as not just a regulator, but one that integrates the scheme so that you don't have variability in what people do.
Many thanks, Dr. Ohiri, for that detail that you have given us. But you have mentioned the need to mobilize more resources, and of course everyone has agreed here
Absolutely.
that the scheme has been underfunded. But we also know that the scheme has been involved in so many scandals. So if you like, some Nigerians who want to say that even with the little that the scheme has, those in charge of managing this money will rather take care of themselves instead of the health of those who are under the scheme. How do you intend to block the leakages this time around, just so that what is available is able to take care of Nigerians?
Well, I can't speculate as to what has happened previously, and I don't have facts as to what you have alleged. What I can tell you categorically is that in the NHIA, the funds that people contribute are earmarked for that purpose. It is to pay for health insurance coverage for people. And yes, I'm just here 4 months, and I'm sure there's a history to the NHIA, but the funds that are being contributed, working with the delegated provision through HMOs in a very transparent manner is always. So a couple of things. One, there'll be full transparency. When we have figures, we have numbers, we have stakeholder engagement. It's transparent what comes in and what is paid as premium. That transparency has to be there. Secondly, with regards to the accountability, I had a meeting with civil society organizations yesterday, and I charged them, I need your input in 3 things. One is the sustained advocacy they have continued to make over the years, both on resource mobilization, but also on helping people create awareness. The second thing also is accountability. From the enrollee, the feedback to us. We have an entire call center to get feedback, but that's not enough. We need people that can give us feedback. From when you as an enrollee go and you see that you're not receiving care or something, there should be a feedback loop that we must establish. And that accountability system has to be there, because that's the only way I, sitting where I am, and the relevant teams can get independent assessments of performance. And we have to have an approach. We have a system in place where we have SOPs in terms of when payments for claims should be made, etc. And ensuring that there's compliance with those things is one of the things we must do in this system. And last, let me say something about insurance. Our role has expanded. The scheme that the NHIA runs is one part of it. The larger opportunities exist in the ecosystem broadly. Now, perhaps the way we started, it was disproportionately focused on public sector workers and the organized large organized private sector. And so everybody still keeps referring to as the scheme, as a scheme. Health insurance is bigger than what NHIA currently runs. There are others at the state level, in the private sector who run schemes. And it's our responsibility to also ensure that there's coherence, ensure that across the entire country, whether it's a private HMO or whether it is State X's scheme, that the same principles of probity accountability apply. In the BHCPF, for instance, we've revised the operational guidelines, including the fiduciary obligations, so that there's more transparency and oversight of that. And this was chaired by the Ministerial Oversight Committee led by the Honorable Coordinating Minister. So efforts are in place to create that transparency, both financially, but also operationally, and getting feedback. And I think we can rest assured that that is a priority, because this is money for people's lives we're talking about. And any money that is misappropriated or that is wasted is somebody not accessing care. And so it is treated with utmost seriousness, and something that, I mean, we are working to strengthen the systems to make sure that across board in the industry that's not an issue.
Now, Dr. Ohiri, while you are doing all of these things, we all agree on one thing: expansion is important. You know, quality. I'm emphasizing quality because I asked earlier, and I'll ask again: is it then safe to tell Nigerians that what they were getting before from the NHIS or NHIA, they can no longer get now? Isn't it better than leading them on, and then they have expectations, and then they go to the hospitals and these expectations are not met? So if we are reviewing downwards because this is what we can afford to do, I think there's something to do. Tell Nigerians what to expect and what not to expect. And second, I pointed out your systems are currently down. Have they been fixed?
Yes. So again, I'll take the two questions. First, it is extremely premature to speculate that we are going to revise it down. Now, every insurance works by having a defined benefit package. Okay. Again, which states very clearly what is covered and what is not covered. At the moment, there are things that are not covered. Every system in the world has a defined benefit package of what is in and what is out. And determining that is a function of, yes, what you can afford, but it's also actually determined your risk pool, the population, and there are lots of factors that go into that. What we're saying is that if you're insured, you know what is in that package.
But you're not getting it now. That's my worry.
And that's what I've said, because you're not getting it because we've had an unprecedented level of medical inflation. It's almost a force majeure. Antibiotic prices have risen by almost more than 400%. Even the pharmaceutical industries complain about it. So it is not, it's an unprecedented thing that it has gotten really bad. And historically, yes, these reviews should have happened before, but it didn't happen. But now we're saying it is, I'm not saying what will happen, I'm saying what is already happening is a review will be done. And once that review is done, yes, we will be clear. There is full transparency on what is covered and what is not covered. And until then, there is no, let's not preempt and begin to speculate. And it might be that, because one of the things that the Act also empowers the NHIA to do is to invest resources. Because if you pack money somewhere and leave it, and inflation then it's not good. But like the practice then in insurance entity or even in PENCOM for pensions, you invest it because that pot has to grow, because it has to keep up with inflation. That has not been the case over the last few years. And this is something that we are doing now to make sure that as inflation, so this thing doesn't happen again, where you will have that trust with people that says like, you're going to come, you can afford this, and when we review the cost, we'll now be forced to reduce it. No, because when these resources are invested and they grow, then it means that it keeps pace with inflation.
Our systems working now.
Our systems are currently down because of some technical glitches, but they've been working. But right now, at the moment, yes, they are down, and and people are working.
When can Nigerians expect them to work? Because it's holding up a lot of people.
It is holding up. It's very temporary.
All right, temporary.
Yes.
Dr. Ibrahim, we do not have so much time, but I'd like you to just give us your final words about this health insurance, really. Going forward, what would you want to see?
I think, first of all, that there's a lot to learn from the past to expand, because everybody is contributing. It makes this scheme more effective and efficient. I think that the government-sponsored NHIA scheme should also log on to the private schemes. They should not be independent. Let one be a citizen's right and the other one be excess convenience or comfort beyond what the basic scheme is. That intermarriage is the message I want to leave, because it's one life. I don't want to do one side government, one side private. Let it be an integration so people, everybody is transparent. Okay, I think those are a few words. The final word too is, please, we do not have a choice. This is the best thing for us. We all have to work hard to make it work.
Okay, thank you very much. I think the DG has clearly highlighted where they want to take NHIA in terms of expanding coverage, quality, equity, and other dimensions. I think what is important now is all of us, all stakeholders, including the media, to work with the NHIA to make this thing work. They've identified the challenges, they have identified the solution. It's not the work for only NHIA alone. How do we help them in terms of advocacy? A number of areas, the funding we are talking about, a number of areas have been identified. We need to advocate so that it sits work with the political class as well. We need to raise the accountability bar. It's not enough to give NHIA more money. All of us, we have to be the watchdog, from the hub to the facility level, to trace the money. And the CSO have done a good job to put in place accountability framework, and to engage with them in terms of, you've received this money, what is the coverage like, what is the quality of care, and is charging us as well to provide some feedback on that. And number three is that we have to strengthen the institution, both at the NHIA level and the state health insurance level. It is the institution that deliver agenda. So currently, of course, there are a lot of capacity, but the largest room in the world is the room for improvement. And lastly, we have to have this type of engagement often, so that as much as possible. But the last thing that I want to say is that when we are a note of sound enough of warning, when we are talking about population coverage, we are saying 7% today. Even when NHI put additional 2 million, don't forget that our population is growing very fast. And that, if care is not taken, NHI might be saying that, oh, we have not had you are still at 9% and all those stuff, right? Because Nigeria is adding additional 6 million people every year by 3% population growth.
What of those that are dying?
Anyway, growth has taken care of both.
Let's get to Dr. Lusoya. Let's get to Dr. Lusoya, really. Vazum, who's joined us via Zoom. Dr. Lusoya, I think one major challenge that enrollees have is that when we alluded to it earlier, really, when you have need to access certain services, you are asked to get what you call, what do you call it again now? That your HMO has to confirm clearance. And when your HMO could take all the time in the world to do that, can we make this much more swift? What are the challenges? Why can't it be quicker?
Okay, thank you very much. We're doing all we can to deploy technology to make sure that authorizations and pre-certifications are given smoothly. And I can say this on behalf of Association of HMOs that most HMOs are technically savvy and have deployed technology to ensure that these authorizations are given well. For the social health insurance scheme, in fact, you don't need authorization for about 70% of the services that are actually needed. What has been happening recently is because of the massive medical inflation that's happening, a lot of providers are refusing the tariffs, are rejecting the tariffs. So something that should not necessarily need authorization, when people want to access it, providers start demanding for a new rate at the point of service. And those are the kind of challenges we're having at the moment. Thank God that the DG has already commenced an actuarial study, and the pricing will be made public very soon, and the reviews will be done. And that will placate a lot of providers. So those are the challenges at the moment, but it will soon be resolved. But in terms of technology, we have deployed technology to make this very fast.
Dr. Lusoya, looks like network is not too friendly at your point, but let's quickly. Okay, Dr. Lusoya, are you with us now?
Yes, I said we have deployed technology. Can you hear me now? We have deployed technology to ensure that authorizations are given smoothly, and also make sure that our contact centers run smoothly. The the few challenges we've had recently with the massive medical inflation, which is like a force majeure, like the DG said, is being resolved with the actual study. Once that is done, a lot of providers will be placated, and there will be no delays in the required issuance of authorization for special services. And I repeat, it's for special services. It's not for everything, just for high-level advanced care that require authorization. Most of the primary care services do not require authorization. So we're deploying technology. We are working around the clock to make sure our contact center provide these services. Then working around with NHIA. NHIA is working on the actuarial review to make sure that the pricing is right, the tariffs are right, and providers can provide these services without any hesitation. Thank you.
But I'd like you to just give a clarification to this. Some patients think that the HMOs are grouped according to maybe your level in society. Is it true that some HMOs deal with, if you like, the bourgeois? When you get to the NHIA office, I'm sure the DJ will clarify that, and then they see, where you work, what you do, and all of that. They put you in a particular HMO that will take good care of you. And for some other people, they put you somewhere else, and then when you go for authorization, you could be there for 3 days, and nobody's attending to you. Is that true? Is it a level playing field for everyone? You can be on any HMO without.
Yeah. We do not discriminate. We don't discriminate. Once you've chosen the plan you want, anybody can actually be on that plan. So for the social health insurance scheme, there's one for everybody. There is no special plan for who is the Oga. There is no special plan for the person at the lower levels. So it's one plan for everybody. For the private health insurance schemes, there may be different plans, but you choose the one that. But the truth about it is that the benefits cost across is the same quality. What is different is the extent of care, is the scope of care. For example, if you're going to access care in your hospital and you want to stay in a
All right, Dr. Olosanya, because of time, let's quickly get to Dr. Ibrahim. I'm sure you want to respond to that question about discrimination in the scheme, having to put in some people in certain HMOs.
Can I choose what HMO I want to be in?
I didn't choose. I mean, they
I'm just asking, is there freedom?
You can actually choose.
But they don't ask you to choose. At the point I was enrolled, for example, I wasn't asked to choose. I just realized I was put somewhere.
Maybe one was overloaded, another one is not. But honestly, nobody can be forced into a particular HMO as far as I know.
But have you experienced discrimination?
No. I think the efficiency is a different thing, where you call a HMO and say, please give me authorization to treat or do this procedure. Some are faster than others. But that's life. It's not a discrimination. It's an efficiency matter. I've commended the scheme for equity already. When you go to the NHS section, who cares whether you are DG or you are just a driver? So I'm very comfortable with that. All I want is that let the DG have NHS opportunity to extend his NHS cover to more advanced cover. We may not have this crisis if people were given that option to say, look, not just this amount. If you pay a little bit extra, you get more.
DG,
that can be addressed right now.
How soon can we get to see the reform kick in?
So first of all, there is no discrimination. And people are not, what you alluded to in terms of people being screened, I think that is quite misleading and false. And I think we ought to, put paid to that right now. Even further than that, I have a meeting even today with the FCCPC about individual choice and promoting enrollee choice in not just, because right now, people choose their HMOs. Sometimes it comes as a company wants and says, this is what I want for my workers. Yes. And they make their choice.
Can you change?
Of course you can change.
Okay.
Because typically when you enroll in a particular plan, there's a defined time period. And we've had many instances where people are like, well, we don't want this HMO, we've moved to this HMO, and that's very much allowed. So if you inquire properly, you'll find that's the veracity of that. But also, they have a choice of their primary care providers where they go. So if you go to a particular hospital or clinic, you're not satisfied, within that you can move and change your provider. So that's individual choice is a critical tenet of the reforms that we're talking about.
Thank you so
but,
much.
in just 5 seconds, how soon can Nigerians begin to feel the impact of the reform?
I believe Nigerians can begin to feel the impact immediately.
All right.
Thank you so much, Dr. Kelechi Ohere, Director General, National Health Insurance Authority. Many thanks for being our guest. We do appreciate it. And of course, we wish you the very best in your assignment. Of course, Dr. Wada Ibrahim, CEO, NISA Medical Group. Thank you so much for being a part of the conversation. We also appreciate Dr. Gafa Alawade, expert in health financing. Good to have you again. Thank you so much. And also our guest in Lagos, Dr. Olumuyiwa Olusoya, CEO is Senior Health Limited and General Secretary of Health Managed Care Association of Nigeria. Many thanks for being a part of the conversation. So we'll take a break now. When we come back, we'll get into the second part of the conversation. Remain tuned.